Hello everyone, welcome to today's lecture on neurotrophic arthropathy, also known as neurogenic arthropathy or just neuroarthropathy, neurogenic osteoarthropathy or Charcot disease or Charcot joints by me, Dr. Mark Spriggs. So let's get into it, if I can. So what is neurotrophic arthropathy? Well, in a nutshell, it is a progressive destructive joint disease associated with sensory loss or sensory deficits. So, what causes it? Well, this becomes obvious when it is the bigger players in degenerative neurological disorders. So, it is a late stage of neurosyphilis. Diabetes, again, late stage of diabetes, which is the most common cause for Charcot joints. Syringomyelia, meningomyelocele, which is a form of spina bifida. Trauma can do it. Cord compression, obviously associated with both trauma but also neurological complications as a result of degenerative diseases of the spine. Alcoholism, congenital insensitivity to pain, and congenital brachial palsy. So clinically, patients will present with symptoms such as altered gait, altered sensation, or loss of sensation. You'll find that they'll have a loss of their deep tendon reflexes. We'll also have a relatively this whole thing will be relatively painless as a result of the neuropathy in the first place. So we've got damage to the obviously the nerves going into the feet and lower extremities mainly, and obviously therefore the changes are not perceived by the patient, so these are usually painless. Joint evaluation will usually be the joints will be unstable, but this will be a painless instability, so the patient won't be able to perceive that the joints are unstable or hypermobile, and therefore obviously in most patients this will be a painful process. You will also have joint enlargement, which will come along with the degenerative changes within the joint, as does the crepitus as well. If you find it early, you'll get recurrent painless effusions or Clutton's joints, which could be the only sign, and lab tests will find you'll tend to find that they'll have negative tests or negative lab tests for joint diseases, but they'll be positive for the cause of the neurological deficits. So if that's obviously syphilis, or if that's due to diabetes, and you'll find that through lab testing, but the patient will test negative for causes for joint disease such as rheumatoid arthritis and things like this. So the pathology, what happens to these joints? Well, there's two mechanisms, or two proposed mechanisms of how this process occurs. The first is labelled as trophic or neurovascular, where the sensory deficit disrupts the normal neurovascular reflexes around the joint, resulting in hyperemia and active resorption of the bone, and you'll see that clearly on the X-rays I'll show you in a little while. Or there's neurotraumatic, where we have somatic muscular reflexes that normally protect the joint from exceeding their safe limits of range of motion. These are lost in the presence of obviously the neuropathy, leading to repeated traumas, which are again not perceived by the patient because of the insensitivity to the affected joints. So the patient is unaware that these joints are starting to fall apart, and as a result of changes in with multiple trauma to the joint, and you will end up with bone resorption and therefore destruction of the joints as well. So the probable sort of sequential steps when it comes to neurotraumatic onset. So you get the loss of sensation and therefore obviously proprioception to the joint. That leads to a relaxation and hypertonia of the supporting structures, particularly muscles and ligaments. This obviously causes a recurrent injury, malalignment of the joint, erosions of the chondral surface, subchondral sclerosis, fracture, fragmentation, and therefore joint disorganization. Radiographically, they will appear as two different types. You'll have hypertrophic, which is associated with the 6Ds, which is things like distension. You'll have increased density. You'll have joint debris, dislocation, disorganization, and destruction of the joint itself. Or it will be atrophic, which will appear as if it is almost as if it's a surgical amputation where the bone has become so destroyed at one end, you'll end up with what looks like a very smooth border around the part of the bone that's left. So it looks as though it appears like it's a surgical amputation. You can also get licked candy stick appearance of the joints, or of the bones in particular, of the tarsals, where the tarsal bones, as you start to lose the distal aspects, the bones will become very thin and narrowed at the far end, making them appear as though they're very fat at the proximal end, and they'll be very thin and narrow at the distal end, appearing like a licked candy stick. And obviously you'll also have absence of the 6Ds found in the hypertrophic form. So, tabes dorsalis is a late consequence of neurosyphilis. It is degeneration of the sensory neurons of the spinal cord, most common in the dorsal roots and dorsal columns of the lower thoracic and the lumbosacral regions, but it can also affect the cervical spine. Up to 20% of these patients will also have the 6Ds present as well. You will have painless swelling, deformity, weakness, and obviously joint instability. The lumbar spine is often referred to as jigsaw vertebrae or tumbling building block vertebrae in their appearance on plain film X-ray. So just here we have a lovely MRI scan of a patient with tabes dorsalis, which can be seen in the mid to lower cervical region of the spinal cord, with the high densities and high signal from that area of the spinal cord. Syringomyelia is a traumatic injury to the spinal cord. It can also be a post-operative complication of spinal cord surgery. It is effectively a cyst that develops within the spinal cord and gradually expands outwards, putting pressure on the surrounding, obviously more external structures of the spinal cord. It's also associated with some tumours, so a hemangioblastoma is also associated with syringomyelia. It results in a gradual and progressive neurological deficit as it expands outwards. Up to 25% of patients will develop neuroarthropathy, usually affecting the lower extremities, and cervical spine is quite typical and is usually got an atrophic appearance. And here is again an MRI scan of a patient with a large syringomyelia, which starts at the level of posterior to sort of C2, C3 region, and it extends all the way down, and you can really see in the lower part of the cervical spine leading into the upper thoracic spine, you can really see that displacement of the inner structures as it puts pressure on the outer structures of the spinal cord. So this is because of cerebral spinal fluid buildup within the spinal cord itself, and it will lead to obviously gradual paralysis from there. Here we have a very typical looking case of Charcot foot, where we've got the bony destruction of the sort of tarsal metatarsal joint regions. You can also see as well some sclerosis within the arteries forming in this patient's foot as well. And here's the oblique view where you can really see that real bony destruction of all of the proximal tarsals in particular. Diabetes, about approximately 5% of all diabetics, usually type 1, will develop neuroarthropathy. Most commonly seen between the ages of 50 and 69, so it's quite a late complication, later stages of the disease, and it is due to obviously loss of pain and proprioception and sensation to the lower extremities, leads to repetitive micro and macro trauma and eventually ischemia. It can also have an infectious process, it's commonly superimposed. It is the leading cause of neuroarthropathy. Forefoot and midfoot, most common ankle and lumbar spine, are also affected. Forefoot is usually looks atrophic. Spine, ankle, and midfoot will also look hypertrophic in their appearances. And with alcohol abuse and alcoholism, it's quite an infrequent finding in these patients, but it's very typically seen in the foot, and it will resemble the same changes that occur with diabetes. So here again, we've got the bony destruction of the tarsals. You can also see again, you can quite clearly see the sclerosis of the arteries, of the blood vessels in this patient's foot. It's also quite distended as well as quite a lot of soft tissue swelling all over the place. So this is obviously one of the 6 Ds, and then you've got the destruction going on, increased density. So this will be obviously multiple Ds present in this particular image. This obviously used to be somebody's knee as well. So again, we've got that large soft tissue, large soft tissue involvement. So we've got that effusions. We've got joint debris around it, and obviously a massive destruction of the proximal femur and proximal tibia, with complete destruction of the tibial plateau. And even from the lateral view, you can see that there's destruction of the patella as well, with that large amount of soft tissue effusion around the knee. Here we have a CT scan of a thoracic spine, where we have so we've got an enormous thoracic hyperkyphosis, and particularly around this area you can see that increased density and bony destruction of the vertebral end plates, complete loss of discs, large vacuum phenomena happening in this segment just here. And if we see it from the APs, you can see it from the front, you've got again huge area of bony destruction around here as well. And here's an MRI scan of the same patient, and here you can really see the high signal density changes around the mid to lower thoracolumbar region, just here, and again massive joint destruction and arthropathy occurring. Here's another diabetic foot, another case from Radiopedia, very helpful resource for you guys to have a look into. And here's the joint debris around the lateral aspect of the foot. Here it is on the AP. The oblique view is slightly better for seeing the other bony destruction, again around the tarsal, metatarsal joints. Not so much soft tissue swelling involved on this particular patient, but again, this is quite a lot of bony destruction going on just there. Here's a CT scan of the same patient again as well. So specifically, you can see again that bony destruction occurring within the joint line through here. So the bone is being resorbed. We've got quite a lot of destruction there. And then this is the nice 3D reconstruction, which really illustrates specifically on the lateral aspect of the left foot here. You can really see that those joint debris around here, and again around the back end of the talus just there as well. And here's an MRI scan of the same patient as well. So loss of signal, loss of bone marrow signal all over the place, really, in the calcaneus talus all over. And this obviously used to be somebody's ankle as well, where again we've got that increased density and the debris around the joint. You can also repair. So this has got a nice example of that surgical amputation appearance of the distal fibula here as well. So that smooth edge around it makes it look as though that could have been done through surgical amputation, but this is due to the bone resorption and destruction of the ankle in this patient. So there we go, guys. That concludes today's lecture on neurotrophic arthropathy. I'll get these lectures uploaded to you as soon as I can as the weeks lead up to your exams. Enjoy your evening. Take care. Bye-bye.